Hello, everyone. Good morning, good afternoon, good evening, wherever you are. Welcome to the ISGyP Live Journal Club. Our theme today is going to be uterine mesenchymal neoplasms. My name is Ian Hagemann. I'm speaking to you from Washington University in St. Louis, Missouri. I'll be your moderator today. We're very glad that you've joined us either today on August 16th or asynchronously on a streaming platform. So welcome to you all. I see that we're already starting to get webinar chat. Feel free to use the chat function to greet each other. That would be a very good thing to do. I'd like to tell you about some of our upcoming ISGyP Live events. Every month we have interesting virtual events targeted at gynecologic pathologists around the world. We'll have interesting case presentations moderated by Rubina Wadi and Andre Pinto on the 23rd of August. And a podcast will drop on the 23rd of August on the classification of vulvar squamous cell carcinoma and its precursors. You can register for these at isgyp.ca, our education site for ISGyP Live. This journal club that you're attending today is global. It's actually two journal clubs. We alternate between moderators in the Western and Eastern Hemisphere and time zones that are convenient for the Eastern and Western Hemispheres. So alternating months will be at the times and on the days that you see here. So next month will be the Eastern Hemisphere. We have a schedule of topics. So this month we're doing mesenchymal lesions of the uterus. Next month, the Eastern Hemisphere Journal Club will address vulva and vagina. And then we'll come back to the West for endometrium. We would love to hear from you if you're an early career pathologist, if you'd like to present at this journal club or at the interesting case presentation. We do take volunteers. You can volunteer yourself if you're an early career pathologist or trainee. You can also volunteer your trainees if you have any young pathologists in mind for whom this would be a good experience. Please just send an email to the people who are named here. For the Western Hemisphere, Natalie Binet; for the Eastern Hemisphere, Karen Talia; and then for interesting case presentations, Jenny Bennett or Rubina Wadi would be happy to hear from you, and we would love to get you on the schedule. So for the main event, we have 3 volunteer presenters today. They have volunteered to take the time to read an article and distill it into a format that's amenable to a 15-minute presentation. Dr. Saskya Claasens studied medicine at Stellenbosch University in Cape Town and completed her medical degree in 2009, worked as a medical officer in neonatology and internal medicine, qualified as a dermatologist, and then started as a registrar in anatomic pathology at Tygerberg Hospital and hopes to become a dermatopathologist. Dr. Miruna Popescu is a PGY4 resident in pathology at the Institute for Pathology and Neuropathology in Ludwigsburg, Germany. And Dr. Vinicius Cabral is a gynecologic pathologist at Diagnósticos de América and a general pathologist at the Grupo Hospitalar Concepción in Porto Alegre, Brazil. And I'll just mention he is apparently having mild technical difficulties, but he is scheduled to present third. So we'll get him in, hopefully. The theme is mesenchymal neoplasms of the uterus. Here are the papers that will be presented. I hope that you have access to them if you would like to read them. These are important papers in the recent literature, and we hope that they'll be of interest to you. And I'll let each presenter read the full titles when the time comes. Okay, about Journal Club. The objectives of the Journal Club are to engage trainees in gaining scientific knowledge and the skill to critically evaluate the literature, to allow trainees and young ISGyP members to get involved in the organization. We provide mentorship as part of preparing these presentations and just engage future leaders from all over the globe. This is truly an international organization and enterprise, and that's really an exciting part of ISGyP. We have a format that we give to our presenters for the Journal Club. I'm showing you this partly to orient you to the presentations and partly so that you realize that if you should happen to volunteer to present, you will have this template to help you. It's the same template that anyone would use for a journal club, addressing the design of the study, its purposes, its methods, the results, the discussion that the authors gave of their data, and then reflecting on the strengths and opportunities for improvement, and then finally how the findings could be applied in practice. We try to choose papers that are practical. So after my introduction, I will stop sharing and let Dr. Claasens take over, and followed by the other speakers. We'll have time for questions. We'll save them to the end to make sure that everyone has plenty of time for their presentation. This is a webinar format. You can put questions in the Q&A box, and we'll moderate them and hopefully get to address them either in real time or live at the end. And I would just note that there's also a Q&A box a chat box where you can greet each other and meet people from other parts of the world. So with that, I'll stop sharing my screen. Dr. Claasens, please go ahead and share your screen. And the other panelists, you are welcome to mute yourselves and turn off your cameras.
Okay, good evening, everybody. I hope you can see my slides nicely. So I'm Saskya, and I'll be presenting from Cape Town. It's about 6 o'clock the evening here. So without further ado, this is the first article. It's from the American Journal of Surgical Pathology, and the title of the article is a Clinicopathologic and Molecular Characterization of Uterine Sarcomas classified as Malignant PEComa. So just a bit of background. Perivascular epithelioid cell tumors, or otherwise commonly known as PEComas, are rare mesenchymal neoplasms, and they have distinctive morphological features. And by immunohistochemistry, it's important to note that they show dual expression of smooth muscle as well as melanocytic markers. So the uterus is a relatively common visceral site for PEComas, but it's specifically at this site where it can be quite challenging to distinguish PEComas from smooth muscle neoplasms. And the authors emphasize that in their experience, one of the reasons are the fact that uterine PEComas can sometimes be very focally positive or even negative for melanocytic markers such as HMB45 or melon A. And then also to keep in mind that smooth muscle neoplasms can be focally positive for melanocytic markers. The clinical significance of this distinguishing between these two entities is the fact that a subset of patients with PEComas can benefit from mTOR inhibitor therapy. So if we look at the molecular profiling, PEComas as a group commonly show inactivation of TSC1 and TSC2, which leads to upregulation of mTOR signaling. And this is what provides the rationale why these patients potentially can benefit from mTOR inhibitor therapy. If we look specifically at uterine PEComas, a subset of them also have been shown to demonstrate gene rearrangements involving TFE3. And therefore, if you can identify either TSC1 or TSC2 alterations or TFE3 rearrangements in tumors that present with this ambiguous morphological or immunohistochemistry features, this molecular profile can support a final integrated diagnosis of uterine PEComas. And therefore, in our era, molecular profiling has now emerged as another means of refining and classifying uterine tumors, especially when you are confronted with a situation where they demonstrate very limited myomelanocytic differentiation. So the study that we are going to look at now was a retrospective case series, and they what they basically did is they described the clinicopathologic, immunohistochemical, and molecular features of 15 uterine sarcomas that were diagnosed as malignant PEComa. And their aims were to look at these molecular features alongside the clinical pathological features, and then also ultimately to see if they could identify any other actionable mutations that may then provide additional options for patient management. So they specifically looked at cases that were originally classified as uterine malignant PEComa, and they did their case selection by looking at the institutional archives of the Department of Pathology at the Brigham and Women's Hospital. And this also included going through the consult files of 2 of the authors. And the study period expanded over 8 years from 2013 to 2021. And they were able to identify 15 tumors that had sufficient material for molecular and immunohistochemistry studies. And then what was subsequently done is that the original H&E sections and the immunohistochemical stains were reviewed by 2 experts in gynecologic and soft tissue pathology. And then the final diagnosis of a PEComa was mostly based on morphology with the immunohistochemical support in accordance to WHO criteria, as well as published series at the time. The gross findings of the tumors as well as clinical follow-up were obtained from the departmental and consultation records as well as the referring physicians. So in terms of the pathologic examination of these tumors, they looked at gross and histologic features, which we will discuss in a bit more detail when we come to the results section. But ultimately, they looked at tumor size. And then in terms of histologic features, they evaluated the tumors for nuclear atypia, lymphovascular invasion, necrosis, mitotic count, and atypical mitosis, which would ultimately allow them to classify these tumors as malignant or not malignant. They looked at tumor borders, cytomorphology, the character of the cytoplasm, if there was stromal sclerosis present, the presence or absence of pigmentation, nuclear inclusions, admixture of multinucleated giant cells, and if any tumors exhibited lymphangiomyomatosis or lamb-like foci. They also performed molecular analysis on these tumors, and this was done by means of a targeted next-generation sequencing, and they used a clinically validated panel which was developed by the Brigham and Women's Hospital, known as the OncoPanel. And this OncoPanel covers coding regions of 447 cancer-associated genes. They also evaluated for gene fusions using the BRAKEMA algorithm, which can detect structural rearrangements across 60 genes, and then they also evaluated for microsatellite instability. The immunohistochemical panel, which was performed on these tumors, is the panel that's listed there, but I will discuss this in a bit more detail later. And then also to note that the staining was scored in terms of the percentage of cells that were positive for this immunohistochemical stain. So if we move along to the results, clinically, this cohort comprised 15 patients with a median age of 56 years. One patient was clinically suspected to have tuberous sclerosis, and this was based on a positive family history, and also the patient presented with angiofibromas. In terms of gross examination findings, all of these tumors involved the uterine corpus and had a median size of 8 centimeters, and then cut surfaces showed tan pink, white to brown, and frequently lobulated characteristics. In terms of the microscopic features, I also want to draw your attention to the images on the right-hand side as I go through these features. Most of the tumors, or all the tumors, expressed aggressive histologic features, and they showed frequent infiltrative growth. The majority of tumors showed mixed epithelioid and spindled morphology, and the minority were purely epithelioid. Other features that were recognized was that of radial arrangement of tumor cells around blood vessels, as well as areas of stromal hyalinization. There was one tumor that showed lamb-like features, and then also none of the tumors showed any features of melanin pigmentation. In terms of the cytological features, the majority of cellular cells exhibited granular cytoplasm as well as cytoplasmic clearing, prominent nucleoli, and there was frequently an admixture of multinucleated tumor giant cells. High nuclear grade was appreciated throughout, but also to note that there were areas that showed less prominent atypia in a subset of the tumors, and there were 2 cases that lacked significant atypia entirely. Then this slide is a summary of the mutational profile that was identified using the targeted next generation sequencing. And that what we can see here is that 7 of the cases, or let's say 47%, exhibited mTOR pathway gene alterations, and these included mutually exclusive variants in TSC1 and TSC2. And then there were also recurrent alterations identified in P53, retinoblastoma 1, and ATRX. And then if I can draw your attention to case number 11, this case had the highest mutational burden and also demonstrated microsatellite instability. And this was also confirmed immunohistochemically with loss of expression of MSH2 and MSH6. And then this table shows a summary of the immunohistochemical profile of these uterine PEComas. So what's not shown in the table is the fact that all the tumors were positive for smooth muscle markers. And then what I've highlighted in green on the far left is the fact that all the tumors, besides one, stained positive for HMB45. And this was in combination with Melin A, as well, with MITF and cathepsin K. And then on the right-hand side, what's highlighted in yellow is the fact that the tumors that showed inactivating ATRX mutations all demonstrated loss of ATRX expression by immunohistochemistry. But if you see the 2 little dark orange marks that I made on the right, this just highlights the fact that there were 2 tumors that did show loss of immunohistochemical expression, but where the gene alteration was not identified. And then this photograph to just illustrate the fact that the HMB45 was often patchy or focal staining in these uterine PEComas. And then in terms of the clinical characteristics and follow-up, so they had clinical follow-up data available for 14 of the 15 cases. 5 of the patients developed local recurrence and 9 developed metastases. 2 patients unfortunately demised of their disease. So we're going to move on to the discussion section now, and I just want to go back a step or 2 and just give some historical context again on PEComas. So they were first described in 1996, but it was only in 2002 that PEComas of the uterus were first reported. And since then, there have been several series that have characterized their clinicopathological features. On a molecular level, as already mentioned, the PEComa family commonly harbor TSC1 and TSC2 mutations, which are modulators of the mTOR signaling pathway. And this is why patients with tuberous sclerosis complex, which have germline mutations in TSC1 and TSC2, also develop PEComas. So more recently, gene fusions and TFE3 and RAD51B have also been identified. Molecular analysis focusing on malignant uterine PEComas have been more limited. Selenica and colleagues looked at 15 uterine mesenchymal tumors that exhibited ambiguous morphology and variable myelomelanocytic differentiation. And subsequently, they classified 4 malignant PEComas, 2 of which showed TSC2 mutations, 1 tumor showed a TSC1 mutation. And then Bennett et al. Did targeting sequencing on tumors that were originally classified as uterine PEComa. And this series included 6 malignant PEComas. 50% showed TSC1 mutations, another 50% showed TSC2 mutations, and 2 showed 2 co-mutations of ATRX. So if we look at the results of this study in terms of the somatic mutations that were identified in the mTOR pathway. These were identified in 47% of cases. And compared to the AMPECT trial, the findings are quite similar, but it is lower than the 2 recent series that I've just described in the previous slide. And the author's explanation for this is the fact that they've included a greater number of malignant tumors in the current study. And it could also allude to the fact that differences in assays utilized or the presence of alterations not detected by targeting sequencing may have played a role. And then the other point that they make is that some tumors may still represent uterine leiomyosarcoma with aberrant expression of melanocytic markers. However, the authors do not say whether they have actually reclassified any of their tumors. In terms of extent of melanocytic marker expression seen in this cohort, they emphasize that several of the tumors showed very focal melanocytic marker expression, but were still found to harbor mTOR pathway mutations, which ultimately supported the final diagnosis as PEComa. Conversely, several of their tumors also showed substantial morphological and histochemical support for PEComa, but then lacked the mTOR pathway alterations. So what they did was a sub-analysis of their cohort, dividing them into 2 groups. Group 1 on the left were tumors that showed more than 5% of expression of melanocytic markers, and group 2 showed less than 5% expression of melanocytic markers. And the significance thereof is that both groups showed a significant component that demonstrated mTOR pathway alterations. And if one looks at the clinical application of this melanocytic marker expression, the authors wish to highlight that immunohistochemical criteria, if they are applied too strictly on these tumors, and if molecular studies are not considered, then a subset of PEComas may be missed. And conversely, the absence of mTOR mutations should also not deter one from diagnosing PEComas, as these patients may still respond to mTOR inhibitors. The limitations of this study, not to be too critical, but the list of immunohistochemical stains performed on these tumors, it was not specified in the article whether any additional stains were performed purely for the purpose of the study, or if these were stains that were routinely done on all of their cases. The other question that one begs to ask is, in the absence of a gold standard for diagnosing uterine PEComas, would everyone agree on the classification of these tumors in the end? And then in terms of the strengths, this is one of the largest series of malignant uterine PEComas to date, and the results expand on those of prior series, confirming that malignant uterine PEComas frequently demonstrate inactivation of TP53, retinoblastoma 1, and ATRX. And they highlight the utility of next-generation sequencing in ultimately supporting the diagnosis of malignant PEComa. How can we apply the findings of this study in daily practice? One thing that I haven't highlighted in the talk so far is the fact that PNL2 in this study proved to be quite a useful ancillary marker to demonstrate melanocytic differentiation. Another application is, once again, to illustrate the important role of next-generation sequencing in the setting of malignant uterine PEComas, especially when one is confronted with ambiguous morphologic or immunohistochemical findings. The caution here, however, is that there is some molecular overlap with uterine leiomyosarcoma. Both tumor types can show alterations in p53 retinoblastoma 1 and ATRX. And to remember that if next generation sequencing is not considered, a subset of PEComas may be missed. And then finally, identification of mTOR pathway alterations in tumors with stronger immunohistochemical support may not be necessary, as these patients can still benefit from targeted therapy. Thank you very much.
Wonderful. Thank you very much. And please feel free to put any questions in the chat for Dr. Claasens, but we'll move on to Dr. Popescu if you want to start your screen sharing and proceed with your presentation.
Of course. Right away. Okay. Yeah.
Perfect.
Yep. Sorry. Good. So, hello everyone. Thank you for the opportunity to speak here today. Okay, hope it works. Yes. The article I'm going to present was published in the American Journal of Surgical Pathology this year by Devins and colleagues, and it is entitled Uterine Endometrial Stromal Tumors with Pure Low-Grade Morphology Harboring YWHAE Not M2 Fusions, reported a case series emphasizing potential for high-grade transformation and aggressive behavior. A little bit of context on endometrial stromal tumors. According to the 5th edition of the WHO, there are 3 main categories of endometrial stromal tumors: endometrial stromal nodule, and low-grade endometrial stromal sarcoma, and high-grade endometrial stromal sarcoma. ESN and low-grade ESS morphologically resemble proliferative type endometrial stroma with minimal cytological atypia and may show, among others, a fibromyxoid growth pattern. The typical immunohistochemical profile of these low-grade endometrial stromal tumors includes diffuse expression of ER, PR, and CD10, with usually negative labeling for cyclin D1. On the molecular level, these low-grade endometrial stromal tumors characteristically show mutations involving JAZF1 and or PHF1, with the most common recurrent gene fusion being JAZF1 SAS12. High-grade ESS are subcategorized based on their molecular profile, with the most common of them being YWHAE not M2 fused high-grade ESS, and the other ones involving V-core gene alterations. YWHAE not M2 fused high-grade ESS is frequently composed of a low-grade component resembling low-grade ESS, especially of the fibromyxoid type, and a high-grade component made up of high-grade atypical round cells. If a low-grade component is present, this will stain as a usual conventional low-grade ESS, while the high-grade component will typically show negative expression for ER, PR, CD10, and a diffuse expression of cyclin D1. The present study represents a series of 5 cases of morphologically pure low-grade endometrial stromal tumors, including 1 ESN and 4 low-grade ESS, harboring YWHAE not M2 fusions. All cases were stage 1 at diagnosis. 2 out of 5 cases showed a fibromyxoid component in the primary tumor with no high-grade areas, and another 2 out of 5 cases showed aggressive clinical behavior with rapid recurrence and high-grade transformation. The main aims of the article are: 1, to suggest morphological and immunohistochemical clues for considering a pure low-grade endometrial stromal tumor with YWHAE not M2 fusions, which should lead to confirmation through molecular testing in an effort to identify potentially aggressive tumors. And 2nd, to provide further evidence for the hypothesis that YWHAE not M2 fused high-grade ESS evolves from a low-grade ESS. So there were 5 tumors selected from the pathology databases of the participating institutions and from the consultation files of 2 of the authors. There was an average of 30 H&E stained slides that was examined. The mitotic index was reported as number of mitoses per 10 high-power fields in a hotspot area. And the immunochemical stains performed at diagnosis included ER/PR CD10, cyclin B1, and additionally SMA, Desmin, and HCAL Desmin. The results were categorized according to percentage of positive tumor cells, in negative being less than 1%, focal 1 to 50%, and diffuse more than 50%. All cases had molecular confirmation of fusion status, and there was a variety of molecular methods used for this, including real-time quantitative PCR, RNA sequencing, and FISH. Regarding the clinical features of the primary of the tumors, patient age varied from 30 to 51 years. All tumors were confined to the uterus at diagnosis. They were stage 1. All patients received total abdominal hysterectomy with bilateral salpingo oophorectomy, and all patients benefited from long-term follow-up, ranging from 6 months to 159 months. Worthy of notice in the context of clinical features is the fact that the ESN in case number 1 showed no recurrence at 84 months of follow-up, and that 2 of the low-grade ESS cases showed recurrences and local recurrences in widespread metastasis at 15 and 155 months respectively. Both patients went on to develop overt high-grade disease with rapid progression, and they eventually succumbed to their disease. Okay, regarding pathological features of the primary tumors, the gross morphology was non-specific. Size of the tumors ranged from 4.5 to 7.5 centimeters. There was extensive myometrial invasion up into the outer half of the myometrium in 3 cases. Histologically, conventional morphology resembling proliferative type endometrial stroma comprised 100% of 3 cases of low-grade ESS and 80% of the ESN. Fibromyxoid morphology made up 20% of the ESN and 100% of one of the low-grade ESS cases. In all cases, cytological atypia was minimal. The atypical round cells characteristic of high-grade ESS were not present. Necrosis was not identified. Lymphovascular space invasion was present in all low-grade ESS cases, and when it's extensive in 3 of them. And most tumors showed a very low mitotic index, with only one of the low-grade ESS cases showing up to 13 mitoses per 10 high-power fields. There was no sex, cord-like, or smooth muscle differentiation. Regarding the pathologic features of the recurrent tumors in the 2 cases that recurred, the vaginal recurrence in case number 2 showed a low-grade, a 10% low-grade component, which was morphologically identical to that in the original tumor, conventional low-grade ESS, and a 90% high-grade component of typical atypical high-grade round cells of high-grade ESS. The early recurrence in case number 3 showed a predominantly fibromyxoid morphology, although this morphology was absent in the primary tumor, so it developed subsequently in the recurrence, with only focal atypical round cells, as seen in the image on the left-hand side of the slide. But in a subsequent distant metastasis to the scalp, the morphology of the tumor was 100% YWHAE rearranged high-grade ESS. Immunohistochemically, I'd like you to focus on PD10, ER/PR, and cyclin B1. Most of the primary tumors showed diffuse expression of ER and PR, which is in line with the usual IHD profile of these neoplasms. But there were 2 immunohistochemical findings that were unexpected for low-grade endometrial stromal tumors. In the 4 out of 5 cases where it was performed, CD10 was negative to only focally positive, while cyclin D1 showed diffuse expression in 3 out of 4 cases, including the SN. The recurrent tumors show the typical immunohistochemical profile of YWHAE rearranged like ADSS. All tumors had molecular confirmation of a YWHAE not into fusion in the primary and/or recurrent tumors, with the tissue from the primary tumor from patient number 2 not being available for testing. So fusion status was confirmed only in the recurrent tumor in this case. And the subset of tumors was also tested for other rearrangements, including the typical JASF1 SUS12 fusion seen in these neoplasms, which were all negative. So in the context of endometrial stromal tumors, the YWHAE not into fusion is traditionally considered highly specific for high-grade ESS. Present study reports the first series of cases of low-grade endometrial stromal tumors lacking a high-grade component in the primary tumors and harboring the YWHAE not into fusion, as opposed to the typical JASF1 SUS12 fusion. Some of the clinical pathologic features of the reported tumors serve as further arguments supporting the already proposed hypothesis that YWHAE not into fused high-grade ESS may evolve from low-grade ESS, one of the most important of them being that 2 tumors recurred as typical YWHAE not into fused high-grade ESS, with one of them showing only scattered high-grade areas in an early recurrence, which may be seen to represent an early stage in the development of overt high-grade disease. Notably, the ESN in case number 1 did not recur during the 84-month follow-up period. The benign clinical course observed in this patient is also in keeping with the typical biological behavior of ESN, which does not recur when completely excised. This case suggests that the presence of YWHAE not into fusion might not alter the prognosis of a pure low-grade ESC in the absence of myometrial invasion. But however, this is based on a single case, so more experience is needed before a conclusion can be drawn. None of the reported morphological or immunohistochemical features alone is sensitive or specific enough to support the presence of a YWHAE not into fusion, but there might be some clues to suggest fusion status. Morphologically, given the fact that the low-grade component of YWHAE rearranged high-grade ESS frequently shows fibromyxoid morphology, the authors suggest that the presence of any fibromyxoid component in a low-grade endometrial stromal sarcoma should raise a suspicion for the presence of the fusion. Indeed, 2 out of 5 cases showed fibromyxoid change in the primary tumors, and 1 additional case developed fibromyxoid morphology in a recurrence. Immunohistochemically, the peculiar immunohistochemical profile that we have seen with CD10 being only focally positive or negative and the diffuse expression of cyclin D1, the author suggests that in a low-grade endometrial stromal tumor, this type of immunohistochemical profile should raise a suspicion for the presence of a YWHAE not into fusion and lead to molecular confirmation. Regarding mitotic activity, although 1 case showed a high mitotic rate of up to 13 mitosis per 10 high power field, most of the tumors showed scant mitoses and occasional low-grade endometrial stromal tumors with the typical molecular alterations and the high-grade mitotic index have been previously reported, so it's completely non-specific and non-reliable. In light of these findings, the author's suggestion is to perform IHC and ideally molecular studies, even in diagnostically obvious cases, to increase the chances of identifying these tumors. Regarding the strengths and limitations of the study, some of the strengths that might be mentioned are the overall long-term follow-up in these patients of up to 159 months. The overall extensive sampling that was done with up to 55 slides examined per tumor, including the entire ESN, the extensive workup that was done, the immunochemical panel, the molecular testing, and the fact that it represents the first attempt to characterize the clinical pathologic features of these tumors. Some of the limitations, of course, include the short follow-up of just 6 months in case number 4, and of course, the possibility of an unsampled high-grade component that cannot be entirely excluded in the primary tumors. The lack of testing for IFI-TM1 is also would have been interesting to see and compare with the CD10 results, but this marker, according to the authors, was not available at the time of testing. And the fact that the primary tumor in case number 2 was unavailable for molecular testing, so the fusion was demonstrated only in the recurrence. And again, overall, this is a case series of only 5 cases. So there was only 1 ESN, so the conclusions that we may draw from this case series are not that solid as of yet. Regarding the applications, the current study aims to improve awareness for the existence of these neoplasms. As per the author's suggestions, paying attention to morphological clues, performing immunochemical studies, and molecular testing, even in diagnostically obvious cases, should lead to a higher chance of identifying low-grade endometrial stromal tumors with YWHAE mapping fusions, which in the individual patient setting may represent a potential adverse prognostic factor that can be mentioned in a comment in the report. And in the scientific setting, testing for these tumors would help us determine their true incidence and ultimately, through further studies, provide us with a better understanding of their clinical pathological features, which will lead to the improvement of follow-up and treatment strategies. And with that, I am done. Thank you again for the opportunity and for your attention.
Okay, wonderful. Thank you very much. And we'll move right along to Dr. Cabral, our third presenter. Please go ahead and share your screen.
Sure. Are you seeing my screen?
Yes.
Okay.
There we go.
So hi everyone, my name is Vinicius. I'm a pathologist from Brazil and I work at DASA and Grupo Hospitalar Conceição. Today I'm going to talk to you about a paper by Dr. Momeni-Boroujeni and colleagues that is called Molecular-Based Immunohistochemical Algorithm for Uterine Leiomyosarcoma Diagnosis. So we know that leiomyosarcoma is the most common malignant mesenchymal tumor of the uterus, and it's diagnosed based on morphologic features, namely nuclear atypia, tumor necrosis, and mitotic index. However, we know that in real life, this can be somewhat challenging. With this paper, the authors sought to determine the most common genetic abnormalities in uterine leiomyosarcoma using NGS sequencing. From the findings of this NGS sequencing, they sought to create a surrogate immunohistochemical panel that could be used on routine clinical practice. And their third objective was to assess the utility of this panel on challenging smooth muscle tumors of clinical practice. First, they designed a test cohort and they used previously sequenced NGS sequence smooth muscle tumors that were randomly chosen and stratified to ensure proper representation of leiomyosarcoma, stump, and leiomyoma. Secondly, they designed a validation cohort for IHC that used cases from routine clinical practice. This cohort had a random selection of smooth muscle tumors and some low-grade endometrial stromal sarcoma, and these cases had no NGS data. Immunohistochemistry was used to confirm the genetic abnormalities found by NGS, and it was composed of 7 commercially available antibodies. All immunohistochemistry was evaluated by 3 gynecologic pathologists who were blinded to the NGS data. This is the panel that they created. but they didn't do all 7 stains at once. The first step is doing P53, ATRX, RB, and P10. If P53 was wild type, then they perform MTAP and MDM2. If ATRX was wild type, they perform DEX. This is because the abnormalities in P53 are mutually exclusive with abnormalities in MTAP and MDM2, and abnormalities in ATRX are mutually exclusive with abnormalities in DEX. Immunohistochemistry was interpreted as mutant or wild type, and we have a variety of expressions. Some are nuclear and the other are cytoplasmic. As we can see on the top row with P53, we have P53's 3 patterns of staining. The first one is wild type because we have some scattered nuclei with variable intensity. The second one is a mutant null pattern where we have no positive nuclei. And the third one is a mutant overexpressed pattern where practically all nuclei are positive and have a strong intensity. The results for the test cohort for leiomyosarcoma showed that all LMS by NGS showed alterations in DP53, RB1, P10, ATRX, DEX, CDKN2A, and or MDM2. 98% of leiomyosarcoma show at least 1 genomic alteration, and 96% show at least 2 genomic alterations. There was no correlation between genomic profile and morphologic features. IHC showed alterations most commonly in RB, followed by P53, P10, and ATRX. The authors proposed that 2 or more abnormal, they don't propose, they actually saw this, sorry. They saw that 2 or more abnormal IHC results were seen in 81% of leiomyosarcoma. For STUMP, NGS showed that 67% of STUMP showed alterations in TP53, ATRX, DEX, or CDKN2A, respectively, because only one showed 1 abnormality. And in IHC, they found alterations in ATRX, P53, DEX, and MDM2. So in the test cohort, there was only 1 abnormality or no abnormalities in STUMPs. Leiomyomas show no abnormalities in NGS or IHC. The results for the validation cohort for immunohistochemistry, it showed that 75% of leiomyosarcoma had abnormal P53 and RB, and 25% of them had abnormal P10, and one of the cases also had abnormal ATRX. Only 25% of STUMP had abnormal P53 and P10, and the sample of low-grade endometrial stromal sarcoma showed no abnormalities. This is wrong. This is show no. There's no abnormalities. Sorry. So with this, the authors proposed that an IHC-based diagnosis of leiomyosarcoma using at least 2 abnormal findings as a 92% sensitivity and 100% specificity. The statistical analysis of the results showed excellent inter-observer concordance in IHC interpretation with a kappa of 0.97 and an excellent concordance between genomic profiles and IHC with a kappa of 0.941. For me, the most interesting part of this paper was applying this panel to challenging cases from their daily practice. So they performed this on 2 cases. The first one was a 9 centimeter smooth muscle tumor with epithelioid spindle morphology, mild atypia, no tumor necrosis, and 7 mitosis in 10 hyperfields. This tumor had abnormal RB and DEX, so that's 2 abnormalities, and this was diagnosed as leiomyosarcoma. The other case is a FIGO 4-stage leiomyosarcoma with classical features. So spindle, myxoid epithelioid features, marked atypia, tumor necrosis, and 51 mitosis in 10 hyperfields. So we wouldn't really use IHC for this. This is easy, right? However, this patient had a polypectomy done 8 years prior, and in this polypectomy, there was only a spindle subproliferation with myoatypia, focal myxoid features, no tumor necrosis, and 6 mitosis in 10 hyperfields. They tested the IHC panel on both samples, and they both showed the same abnormalities in P53, P10, and HRX. Because of that, the authors diagnosed the polypectomy specimen as leiomyosarcoma using this molecular-based IHC diagnosis. And this is despite the polypectomy not having sufficient morphologic criteria. This paper showed that leiomyosarcoma has a distinct NGS and IHC profile from stumps, leiomyosarcomas, leiomyomas, and low-grade endometrial stromal sarcomas, and that any smooth muscle tumor with 2 or more abnormalities is invariably leiomyosarcoma. The authors proposed that the absence of abnormalities, especially when morphology is insufficient, renders diagnosis of leiomyosarcoma highly unlikely. And now the authors applied this IHC panel for stump and other challenging smooth muscle tumor cases on their daily practice. This is the image that summarizes this study, and I think it's the one we're going to be referring to in our daily practice. And it is their decision-making algorithm for smooth muscle tumors. So if you have an atypical smooth muscle tumors and it has morphologic criteria for LMS, then it is leiomyosarcoma. If it doesn't have morphologic criteria, you can do P53, ATRX, RB, and P10. If 2 or more of these results are abnormal, then it is leiomyosarcoma. If none of these are abnormal, then you can do MDM2, DAX, and MTAP. If 2 or more are abnormal, then it is leiomyosarcoma. If only 1 is abnormal, then you're stuck between stump and leiomyosarcoma. And if there are no abnormalities, then your decision is between leiomyoma or stump. I believe that the strengths of this study are the mapping of genomic and IHC abnormalities in smooth muscle tumors, and that is based on a commercially available IHC panel. However, I think there are some limitations and improvements. The first is that these antibodies, yes, they are commercially available, but they are not widely used by most laboratories, especially in the developing world. I also believe that IHC interpretation is not so easy, and this is something the authors themselves point, especially when it comes to RB, that can be very focal and patchy. I would like to see this study reproduced and validated by other groups. As far as I know, no other group has validated this. I would also like to see this tested on a bigger sample, and I'd like to see this NGS and IHC testing on myxoid leiomyosarcomas that were not included in the study. A question that the authors raised is that are stumps with 1 IHC or genomic abnormality different from those stumps with no abnormalities? The authors propose that this can be readily implementable in routine practice, and it has a possibility of diagnosing early and morphologically insufficient tumors. And I make this question for you, for the audience and the panelists. If you have read this paper, are you using this IHC panel in your practice? And would you make leiomyosarcoma diagnosis based solely on IHC? Personally, I don't think I would make a diagnosis based only on IHC, but maybe it could help me, or at least help me to write some sort of discussion on challenging cases. And that's all I have for today. Thank you.
Hey, thank you very much, Dr. Cabral. We do have a comment / question in the Q&A about your paper. One of our attendees points out that your malignant recurrence in this case series may or may not be related to the original polypectomy specimen from 8 years previous, because the patient may simply have a propensity to develop smooth muscle tumors. What do you think?
Yeah, I think it could be this, but I find it curious that they both had the same abnormalities. It doesn't imply causality, but yeah, I think we need to study more of these cases. I think it's only one case. Maybe another interesting study would be a series of insufficient cases that have a follow-up and then become or leiomyosarcoma, and see if this really is something that can be validated.
Yeah, okay, very good, thank you.
Thank you.
Yeah, Dr. Claasens, I want to give you one question that came across the Q&A. There was a little discussion of whether leiomyomas can have melanocytic differentiation. I wonder if you have any opinion.
Leiomyosarcomas, if they can have melanocytic differentiation.
Yeah.
Yeah, I think from the article, that's something that they highlight, is that they can also show focal, at least staining with your melanocytic markers on immunohistochemistry. And that's why it can sometimes be a bit of a pickle to, on morphological grounds and immunohistochemistry, in the absence of having your molecular profiling done, to sort of be confident in saying this is a malignant PEComa versus a leiomyosarcoma.
Good, thank you very much. Well, in the absence of other questions, I think we're ready to close this webinar out, but I want to thank all of our presenters for being here. This has been really a great session and some great papers that I hope you'll take time to read and reference. So thank you, everyone, and we'll see you next time.